We'll fill some time with that. So, like I said, my name is Joe Sherrell. I'm currently the fire chief in Bixby, Oklahoma, a suburb of Tulsa. Um, History of my career is I did EMS transport for Tulsa's EMS service for a while, then joined the Tulsa Fire Department in 2006. Did 15 years there, promoted to the rank of captain. Spent a lot of time in the EMS office, kind of the middle part of my career there. Came over to Bixby in 2022 to start the ambulance service from the ground up. Weren't operating ambulance service at that time. And then in about a 2-year period, promoted from EMS chief to deputy chief to fire chief. So way faster than I anticipated. So kind of the background here is extremely fast growing community, fast growing fire department. We've doubled our membership in about a 4-year period. So lots of growing pains going along with that. So.
Okay. Chief Lemery, do you want to introduce yourself too? So when you're ready to go.
Sure. Yeah, my name is Justin Lemery. I'm on the Tulsa Fire Department. I have been on for 19 years and in my current position for 6, kind of leading the EMS office and mobile integrated healthcare. I think in alignment with my discussion today and my presentation, when I got in the office in my position in 2020, we had about 6 people in the office, and today we have 23. And most of that growth has been through mobile integrated healthcare, something I'll touch on in my presentation today. But I've really been responsible for advancing the mobile integrated healthcare, managing a budget, and I'm talking about budget today and managing that and diversifying your portfolio. And so I've got a lot of grants and manage a couple $1 million in grants. Something I'll highlight as important in my presentation. But second generation firefighter, been in my family my entire life and prior to me. So very excited to speak with you all today about this content and this information. So that's all I got.
That's great. Thank you. And I'm sorry that you couldn't come to Montana. We'll have to make sure that happens sometime for one of our conventions. We have some really great conventions. So we have people from all over the state on today. We have people from all different departments. We have people from volunteer, combination, and career departments. So a little bit of everything. The majority of our departments in the state are volunteer, but we do have some career folks on today, which is great. So Chief Joles, are you ready? Or
well, I would love to say that I am, but every time that I enable editing on the presentation, it turns it to a different language that none of us can speak. So I'm just going to ask Joe and Justin to just share their presentations individually, and then I'll do the same when it gets to me. And I'll give Joe a minute to get that set up, and I'll just introduce myself as well. Kevin Joles, just outside of Kansas City, where I hope to see some of you next month at FRI. It'd be great to meet you in person since we were unable to make it to Montana tonight. Currently the EMS section chair for the IAFC, that role will change in August, and someone else will take over that role. Brian Consalves from Sacramento, California. But we're excited to be able to do this for you all, and apologize about the technical glitches. But I'll talk a little bit more once it gets to me, but I'll let Joe kick it off with his English slide deck.
All right. Is that English?
Looks like it to me.
That's good. Yeah. Okay. So that burned about 10 minutes of my time, so I'm almost done. All right, so quick learning objectives. We're going to talk about knowing yourself to lead yourself, basically. The 5 voices and kind of some personality traits, why communication matters, active listening, and then conflict resolution. So recently, probably 6 or 8 months ago, my executive staff and I attended a kind of executive leadership 2-day retreat to get to better know each other, because we were all doing our roles. And we did a personality test, for lack of better terms, that kind of shows how you communicate. On your screen, you'll see multiple different ones. There's probably 20 or 30 or maybe more than that out there. Everybody's probably heard of the Myers-Briggs, which is usually pretty expensive and super detailed. There's DISC, the color code, which is what Oklahoma has an EFO program. The color code is what they use, which basically tells you the same thing. So your color identifies whatever color your chart shows, kind of shows your communication style. and kind of extrovert, introvert, that kind of thing. Clifton Strengths is another one that will show you your strengths, and the research shows that you can do a lot more with your strengths than your weaknesses. So if you really concentrate on building your strengths, it will become categorically stronger, while your weaknesses only improve slightly. So really emphasizes working on your strengths. And the 5 voices is what I'm going to kind of concentrate on tonight, which identifies how you naturally contribute and experience team conversations. So if you don't know how you react, or you don't know what the personality or the communication type of those you lead, it can really lead to conflict or miscommunications. And there's a link down there to that website. All of these, I think, are available, at least some portion of them, on there for free. And then, of course, they'll want to sell you the remainder of the report. So I encourage everyone to jump on there and do one of these if you haven't before. Some of you likely have and kind of already understand your personality traits and how you communicate. So this is a quick a talk on the 5 voices. So similar to it's based on the Myers-Briggs. You could take a nurture and you get your letters that equal what you would see in the Myers-Briggs. It kind of shows you the population breakdown and kind of whether you're present-oriented, future-oriented, and kind of how you communicate. I don't know what this will do when I click on my results down here. Does it show my screen, Kevin?
Yep, showing your results.
Okay, perfect. It worked. So this is I took the test, so I demonstrated here, and as you can see, it identifies me as the nurturer guardian. I want to make it a little bigger because I can't see it, and tells you how you communicate, how you feel a lot of the time, and most of these I can relate to. And your spouse, if you took this home, would probably say, "Yep, that's you." So it really highlights what you like, what you dislike, how you communicate, where you rank on the population. So how likely is the person across the table to be similar to you, and kind of your champions. And then maybe the most important is what to watch out for. So as a nurturer, is what I identify as, is a fear of conflict, which doesn't work out so well if you're in a leadership position, or especially an executive leadership position. So it kind of helps you identify why some of these are strengths, where that could be a weakness, and what you have to watch out for, so you can be prepared for those. And when it's time for a difficult conversation, in my case, because I'm not a huge fan of conflict. I know most people don't enjoy conflict. There's your few. You probably have a couple that work for you that enjoy it, but most people in the leadership roles don't enjoy it. Some are more likely to jump into it than others. And then when you're looking at your counterparts, if you've had your executive team do this, or your the company officers that work for you, or whatever your structure is, once you identify, let's say you're the person you're leading or managing, it tells you how to empower them. So if you want to empower me, let me speak first, because I'm generally going to be kind of quiet and reserved in a meeting, and then kind of show that you value the contribution, and then kind of help them demonstrate the competence. So that's just a quick look at this, and then you can keep going down, as you see here, and it ranks you in order of the 5 voices you are, and which one you're stronger in. So let me see if I can get back to my slide deck now. Back on the slides?
Yes.
All right, perfect. So that's just a quick look at the 5 voices. So I think it's extremely important for you to know yourself a little better. I said earlier, you're going to know yourself to lead yourself, and to create or to quote Viscuso, if you can't lead one, then you can lead none. So make sure you're familiar with yourself as you jump into these roles. Building culture through communication. So I think if you poll any organization, whether you're talking about your major oil companies, or your convenience store chain, or your fire department, everybody's going to say the weakest part of your organization is communication. Most of the time, they're going to say you miscommunicate, undercommunicate, micromanage, but all related to communication. And so that identifies communication as being probably the most important thing we can portray as leaders. So trust and retention. If you can't have a simple conversation with your crews, from firefighter all the way up to the fire chief, then you're going to have a difficult time building that trust and potentially retaining that trust or retaining the people. As we know, the fire department doesn't draw and retain quite like it did, 20 years ago. And I think, as we all know too, like once you get that trust, you're one or two statements or one or two actions away from losing that trust after you spend years getting it. So trust and retention is super important. Station visits. I know she mentioned that you're all from different sizes, from smaller volunteer departments to maybe some metros. So station visits can be difficult for some and easier for some. I have two stations, and it can be difficult for me to make it to the station that I'm not stationed at. So making those intentional, but informal. So make sure that you're swinging by and having those informal conversations, kind of as you see in the picture there, where you're just having a conversation around the coffee table. Doesn't have to be super deep department related. Just some general conversations about family and what's going on in life can be super beneficial as well. So different ranks, obviously. If you're a battalion chief, then you're probably making station rounds more than if you're the fire chief or an executive role. And then the chief officer's role in building organizational culture. Whether you know it or not, or your actions, you're building culture, whether it's positive or negative. So you're leading by example, whether your example is positive and uplifting, or if it's dragging the department down. People are seeing how you lead. So you are leading by example, regardless of if it's a good way, in a good way or a bad way. So I think that building that culture of open communication can be tough to start sometimes. You're probably going to hear some stuff you don't want to hear. But when from all the way down to the rank of firefighter up through the chain, they feel comfortable swinging by your office and saying, "Hey, Chief, can we talk for a second?" That's when you know you're getting that culture built. And sometimes the conversation may not even be fire department related. I know many of you, besides chief officers, you're marriage counselors and life coaches, and telling your folks not to buy the $90,000 truck. So a lot more communication outside of just your professional role. Active listening. Obviously, some of these photos are AI generated, and my goal for this picture was the guy in the middle is supposed to be looking down at his Apple Watch. I don't know how many of you have that habit. I'm horrible about that because my text messages come through my watch, reminders, phone calls. So when you look down at your watch, it looks like you're checking the time. So be cognizant of what's distracting you and what's breaking that eye contact with whoever you're talking to, because it looks terrible when you're looking at your watch. So again, maintain that attention, put down distractions, face the speaker, things that seem super simple, but that we often forget in the digital world we live in. We're so used to texting and emailing. We can have a difficult time having conversations sometimes. So we're more connected than ever, technology-wise, but conversation and connection can also suffer because of that. The other tip there is avoid interrupting. I would say one of my greater weaknesses in communication is I'm so trying to prepare for what I'm going to say when you're done talking that I may not listen to you or let the conversation finish, or occasionally feel a need to interrupt. Some personalities are a little stronger at interrupting than others because they want to get out what they need to say. All that does is convey that you feel that your statement is more important than them. One of the things I struggle with there too is I'm not great with names, and I don't pay attention enough when somebody's introducing themselves because I'm thinking about what I'm going to say, and now I've missed your name, and then you look silly a couple of days later when you run into that person at the conference and you can't recall their name. Use clarifying questions. So we've all learned about asking open-ended questions, not just yes nos, to help them kind of draw out what they're trying to say and showing that you understand, and then going back and paraphrasing those key points. Those things that are really important. Say it back to them in your own words to signify that you have picked up what they're laying down. So to me, the biggest thing is the technology distractions. I don't know how you guys do meetings, but we have a command staff meeting once a month where we may have 14 or 15 people in the room. And if everybody's on their phone with the side conversations, the meeting can get out of control pretty quickly, and then nobody gets anything out of it. So make sure you're practicing those active listening skills. Setting the environment. This is kind of a skill or trait I picked up years ago and try to use it to my benefit when I remember to do it. So you can set up the conversation with the environment. So however your office is set up, if you decided to sit in the conference room versus at your desk, or if you're around the recliners and the sofas in the station, is going to give a completely different environment about what the conversation is going to be. So you see the picture on the first picture there, a very relaxed conversation. I don't know what fire chiefs are wearing red ties, but that's what AI thought he should be wearing. So he's wearing the red tie as the chief, and everybody's having a good time, laughing and drinking coffee. So probably not super deep a department discussion there. The next one is more of the conference table. My people have probably picked up that if you walk into my personal conference room and the shades are down, it's probably going to be a tough conversation. So that's taking a little bit more command of that room and command of the conversation. So it's probably going to be a deeper, maybe discipline related, or you really need to get an attention conversation. That third picture you see there, you see the two guys sitting on the couch together, then the comfy chairs facing each other. That kind of lets the guard down of this isn't quite to the level of that conference table. It's a little more relaxed, a little more personal conversation. And then there's always this last picture is supposed to portray the chief sitting in kind of the guest chair in one of his command staff's offices. So it's not uncommon for me to go to my staff's office and sit in their guest chair, if you will, and have a conversation. So that's kind of takes that protection of your desk away from them and lets them kind of control the conversation a little more. So just a couple of tricks on setting an environment that I picked up along the way that I think do a pretty good job without you having to say anything. And then the myth of difficult conversations. So there's books about it. There's classes about it. I showed you earlier that conflict is not my favorite thing. So initially I was pretty bad about putting out those difficult conversations because I didn't want the conflict and that nurture. I didn't want anybody upset. So what I have learned through some research and mostly just through experience is very seldom is a difficult conversation going to be as bad as what you've built it up to be. Maybe twice I can think of that the conversation went as bad or worse than I'd anticipated. Usually it's way better and you leave with some resolution and some relief. So again, that expectation versus reality, we anticipate and build ourselves up and think about it for days, and it's usually not near that bad. I've also learned with my personality that I'm better off to handle the conversation quicker, because if it's something I really need to discuss, I'm less likely to do it if I wait too long. And I'm usually able to control my temper, so I can have the conversation when I'm a little bit heated, versus 3 days later when I've kind of started to let it slide off. Some of you may have the personality where it's not ideal to have the conversation immediately when you're still kind of worked up, and you may delay that. So that's back to knowing yourself. Preparation is key. So having your talking points, knowing what you want to talk about, maybe taking notes. I definitely do this when it's time to have a meeting with my union president. I call him silver tongued because he can come in here and there's times he'll leave the office like, man, what did he just talk me into? So I don't know if you guys have ever felt for that. So I try to be a little more prepared for his meetings because I know he's always got an agenda. Assume positive intent. Most of the time, these conversations are people trying to get on the same page and move in the same direction. So don't always assume that a conversation has to be somebody after you or be negative. Focus on the behavior, not the character. So if you're discipline related or something where the person you're talking to is getting maybe corrective feedback or something like that, focus on the behavior, don't attack their character, focus on specifically what went wrong. And then the relief of resolution, 98% of the time once the conversation is done, I think both sides of the table feel better, and then you're not dreading it and adding those gray hairs to your head. So that was a pretty quick rundown of this. So the key takeaways: know your voice, know your personality. If you don't know yourself, you're going to have a hard time communicating well and understanding what those around you need, and to know what you'll fall for and when it's time to have a conversation. So you have to know your personality. So I encourage everyone to take one of those personality type tests if you haven't before. Understand your people. So like I said in our executive retreat, we all took the 5 voices framework. So now I know each one of the ones that I directly lead or directly manage. I know if they're introverted or extroverted, or what kind of communication style, or one of the, I think the key things I took away from is what they recognize as a compliment or reward. And it's not always money, it's not always time off. Sometimes it's a pat on the back, sometimes it's a handwritten note. So you may be rewarding people with things they don't see as a reward, which is just a waste of your time and money. So find out what motivates your people. Practice active listening, as we talked about. Put the distractions down, control the room a little bit, maybe manage the time so people aren't so quickly to get to their phones, because we have a hard time setting those down for very long, especially in our careers. And maybe the most important thing is embrace the difficult conversation. Funny enough, when I was putting these slides together yesterday, I'd had a little interaction with my deputy chief yesterday, and I'm writing this, and I'm thinking, man, I've got to have that conversation with him. So I actually opened that conversation with it like, hey, yesterday I was preparing this slide, and we need to chat about something. So, you also got to practice what you preach and demonstrate it, because, like I said earlier, you're leading by example, whether you realize it or not. And I think all these things related to communication has been falsely identified as a soft skill. When it's a specific class in the academy, or maybe even a professional development, we call them soft skills, which to me makes it seem less important. So it's a human skill. If you're a leader of any kind and you can't communicate, if you can't have difficult conversations, unfortunately, it's 90% of your job, and that's going to make your job very difficult. That is it. There we got one word scrambled there, my name. I was actually in Montana last year. I went all the way up to Glacier, so I love your weather and wish I was there right now. We had 120-degree heat index yesterday, so I would love your climate right now. There's my contact information. Feel free to reach out if you have any questions or want to chat about anything we talked about. And I don't know if we entertain any questions or how you guys want to handle that.
I don't know if you guys want to take questions now or just wait till the end. It's up to you.
I think we're fine to do questions now if anybody's got them for that section.
That works for me.
For questions, you can absolutely type them in the chat and I'll read them, or you're welcome to turn your camera on and your microphone and ask them directly. Any questions for Chief Sherrell?
Let's see. How receptive was your guys to doing the personality tests?
So it all came as part of that executive retreat, which when I was interviewing for fire chief was one of my top things I wanted to do. And a little backstory on it. So I was the new fire chief. My deputy chief was brand new. My fire marshal was brand new. My EMS chief, so my entire executive staff was brand new. So like we didn't really know each other at all. So it came as this guise of this executive retreat. We actually went to Oklahoma City, spent the night, and part of the pre-course work was to do the personality test. So they were pretty receptive to it. And when we got there, it was kind of mediated by the coach, and it turned out the first 8 hours we spent together was extremely beneficial to the group. So my executive staff was very open to it. My next goal is for my battalion chiefs to do it, and I've been a little bit reluctant because I don't know if they will be quite as receptive as the staff I deal with every day. But it's been extremely beneficial to my staff and how we communicate. So to answer your question specifically, my staff took it pretty well.
And Chief Sherrell, if I could chime in there too, I've had my staff do a similar test, and they were fairly receptive. I think the benefit, in my opinion, is people get to know themselves better as well, which it's I guess my opinion is kind of surprising. A lot of people don't know a lot of their strengths or weaknesses or some of those things, and these tests can really help them out. And I do believe it helps personal and professional. It's a win-win. So I had about 20 people take it in my office, and they enjoyed it. They were happy to do it.
And if I can add one little bit as well, I was with this organization for 11 years, and then I left for 7. Was fortunate enough to come back. And the last couple of years that I was here, we were we were mandated to take it. Of course, nobody wanted to do it. But then when we did take it, they took the top 3 strengths and they put them on a note card with your name on it, top 3 strengths, and they put it right next to on your door frame. And so anytime somebody was walking by, you could see them looking up at that. And over the years, as that dissipated and it wasn't really that big of a deal, it was good to know that when I came back 7 years later, there was probably 4 or 5 of the people in the same offices that still had theirs up, and it reminded me what their strengths were, so that when I did come back to the organization, I was able to go in there and have a pretty good idea of how I could play to their strengths, as opposed to going in a little bit blind. So, if you're willing to post them, it always helps as well, because it does frame your conversation with these folks a little bit different than maybe you would have done in the past.
I think, Kevin, I've also seen like signs. We haven't done it, but like, this is how you communicate with me. If you want something from me, this is how to basically talk. Like, if you want something from me, be direct. Don't spend 30 minutes telling me the story. So my staff has learned that. Um, Not perfectly yet, but they've kind of identified it, the better way to communicate. And I think it's definitely an investment to do executive coaching or kind of the retreat thing, but having that third party in there that doesn't know anybody was extremely helpful for some of us working out our communication differences, specifically between my deputy chief and the fire marshal. Like, I'd spend the money again just to get those two talking like they are now. So hugely beneficial. Any other questions?
Not seeing anything in the chat. We'll have hopefully a little time for more questions at the end. So.
Okay.
Okay. I will start sharing my screen. Everybody should see this slide, I hope.
We do. Thank you.
Yes, perfect. Okay. So I'm excited to talk a little bit about foundations for sustainable EMS, and really just budget, value, and the future of fire-based EMS. Obviously, that's a big part of the work that I do, and really for everyone here, I at the end of my little presentation, I hope you really have 2 big takeaways, and they are this. Because I think at the end of the day, there's a lot of ways you can do these things and approach this. But 2 big takeaways: have a method to your madness, or a methodology behind what you're doing. And that's for your EMS, and that's for your department as a whole. And then tell the story. So as we talk about budget dollars, a lot of people typically don't put numbers with stories, but I think it's incredibly important that you pair both together. We're all, at the end of the day, money is the big driver for all that we do. And I really believe that your ability to tell the story along with and backed by data is incredibly important. So with that, we'll kind of get into my presentation today. We're going to highlight four items, which are budgeting fundamentals, demonstrating value, identifying EMS needs, and funding the future. And so really want to talk about some of those financial architectures that we see around budgets. And we won't spend like a ton of time on this, but I do want to make sure we're all talking and speaking the same language. And then demonstrating the value, which I think is one of the more important items that we can do as fire service leaders. And then continue to identify EMS needs. So nobody's telling our story for us. This is what I often say. We can't assume that everybody knows our pinch points, our pain points, or the issues we're trying to solve. And so we have to identify those needs and make sure as fire service leaders, we're addressing those needs, both internally and externally. And then the funding future, I'll end just a little bit with kind of what I see moving forward and ways that you can provide some sustainability for your programs and the work you're doing. And I believe, if I've got it correct, Montana's got some good opportunities. So here's a question to think about: if EMS is a majority of what we do, why is it treated like a minority of what we fund? Regardless of where you look in America or where you look over the country, most fire agencies, fire-based EMS, are responding to a majority medical calls. And so they're a big part of our service, but often thought about as kind of an afterthought or a supplemental to our service. I really encourage fire service leaders to, or like I tell some of the people in my department, is you might as well start hitting your head against a wall, because EMS is here to stay, and the fire service has the opportunity to provide a lot of value in this space. And I would even say a lot more value than we are. And when we do, we can really invest and really improve the public health and community health in our communities. So I really hope that I communicate that here today. Five distinct funding categories in modern fire-based EMS. And when you look at EMS budget specifically, you're really competing against the number one is the general fund, right? And so I have these conversations all the time is, we in the fire department have to fund a lot of items, whether it's fire trucks, PPE, SCBAs, but we also have to fund the EMS. And EMS is fighting to get the right amount of budget dollars to sustain those types of operations. You also compete against third-party billing, state grants, federal grants, and value-based partnerships. So for example, I'm trying to get 3 different grants right now, and I'm competing against anybody and everybody to get those grants. One of those is a federal grant with SAMHSA. And so you have to be able to not only quantify that, but be able to tell the story outside of the numbers. So we'll start with section 1, budgeting fundamentals for fire-based EMS. Which is the financial vocabulary and structures to speak fluently before walking into a budget hearing. You definitely don't want to walk in at a disadvantage. And so for chief officers, I think it's incredibly important that you know the various budget structures. And I think we could probably poll everybody here today, and everybody may use something a little different. You'll hear me talk about this in the very end of the my part today is I really think when we talk about funding coming in, you must really have a diversified portfolio. But to start there, you must be tracking it in some way, shape, or form. So the 4 that I have listed, and there are others, but line item budgeting is very good for tracking spending by category, such as salaries, fuel, supplies. But it doesn't really highlight the outcome or performance. And I think that's a missing piece, and a really important part. There's program budgeting, group costs by service lines, such as this is our 911 calls, this is our MIH community paramedicine, this is training, and you name it. You can go down the line of different types of programs. The point is you're saying my MIH program costs me $100,000 a year, my 911 response costs me $1 million a year. Whatever that is, they're broken up into categories or by program. Then there's performance-based budgeting. This has funding requests to measurable outcomes, so such as response times, readmission avoidance, patient satisfaction. And I believe a very strong tool when you're with city leaders, that this has to be a piece of your data telling story, is what is the performance of our apparatus. We operate a pretty robust mobile integrated healthcare program that addresses a lot of community risk and a lot of community items. But if we were not, for example, transporting those people to different destinations, or outside of the hospital, we might not be hitting some of those metrics or those performance-based metrics that city leaders want to see, and they are funding these programs. So performance really aligns with, hey, we are changing outcomes, we are impacting outcomes. So I think that's a good budgeting item. And then zero-based budgeting, it is a tough one. We are actually, our department for operations is moving towards a zero-based budgeting, which means ultimately you're justifying every single item every year and why you need it and what you need it for. So it's good in regards to that you're justifying it every year and you're staying on the point, and validating your programs, but it is a little more tedious. And so somewhat excited, I guess, to start that. Understanding the cost structure beneath every call. So I think this is really important. And really in the fire service as a whole, I've seen so many different ways of saying, what does it cost to provide our service? Do we take the number of runs and divide it by the total operating budget, and that's the cost? Do we use it off FEMA reimbursable rates? There's a lot of different ways to look at this, and I'm not seeing a lot that consistency across the board. But for this context, there's fixed versus variable costs. So fixed costs are, station costs, station leases, base salaries, apparatus financing, insurance, some of those costs that are consistent, you can plan for and. Then there's variable costs such as fuel, disposable medical supplies, overtime, consumable equipment. And so really important that you separate the two. We've dealt with this. I'm sure most in this room or on this meeting today have dealt with justifying overtime expenses, justifying, why you have so many people off in a day, or injuries or paternal leave, whatever it is. You've got to be able to outline both fixed and variable cost for your budget. And then looking to the right, there's the indirect versus or direct versus indirect, or the cost per unit. So direct costs attached to a specific unit or program. So a medic unit's crews, drugs, maintenance, whatever that costs to operate that ambulance or that fire truck. I think in ambulances, it needs a way to remember this. If we use 20 supplies or whatever we're using off of those costs or off that ambulance, would be direct costs to operate that unit. Indirect and allocated costs are spread or shared overhead. So dispatch, administration, IT costs, things that really are supporting your everyday operations. And then you see the Chiefs tool down there, cost per unit hour and cost per transport, turn an abstract budget line into a number that a city council or county commission can actually evaluate against the value delivered. So unit hour utilization is a big item, and that how busy is that apparatus? How and a question that I would ask in this meeting is, what is the cost per hour for your unit? Do you know, like when a fire truck or an ambulance or a mobile integrated healthcare or whatever unit you have responding, what that cost is? How long? How are they available to respond? What's their availability? If they are transporting, what do the transport times look like? Being able to know those figures and those numbers is really important to advocating for your salary or advocating for more units or more staff. And so knowing those figures is really important, and definitely something you should know before you go into the meeting. Revenue reality. So we talk about fee for service alone won't carry EMS. So there's a couple things, reason for this. Payer mix pressure. So you look at the aging population, you look at the age of population and Medicare and Medicaid reimbursement rates. For those who are billing for those, they are not enough to recoup the true cost of providing that service. So if you have a transport service that's doing that, you're not getting all that return on investment. For those who aren't transporting, you're getting even less. I mean, you're not charging Medicare, Medicaid, or getting those reimbursement for those fees. And that's a similar situation for some of my units. We don't get any billing for some of our MIA services right now. So payer mix pressure. So we see that is a big problem. Even if you're getting paid, you're not getting the right amount of money. Cost outpaces revenue. So labor, apparatus, consumable costs have risen faster than reimbursement. And so it's a structural gap, not a one-year budget problem. And there's a lot of work going into the space right now of trying to get proper reimbursement for services provided, whether you're just a fire-based response agency or you have a transport service or whatever that looks like. Getting reimbursement for those services is a big deal. One things we talk about are cardiac arrest that are DOAs or that we don't transport. What's the reimbursement like on those? Or lift assist, or people when they don't get transported, what are we able to recuperate in cost? And then volume-based billing rewards the wrong thing. So traditional billing pays for transport, not the outcome. This is a big one that if you look at any kind of reimbursement structures going out, everyone's moving towards value-based, which ultimately means what's the outcome? So some things we look at is it's not just we went to client or we went to individual 5 times, and so we want to charge 5 times, but it's the paying structures are more aligning with we went to an individual's house we went to an individual who was not connected to a PCP or healthcare, and now they are. And now they're not calling 911 or going to the emergency department. There was a change in outcome. and that person's health has improved, now we're going to reimburse that. Or someone who's unhoused is now housed, or someone who didn't have food now has food. So outcome-based care, or avoiding those readmissions to EDs are going to be the things that are rewarded in the future. Demonstrating value to secure future funding. So elected officials fund what they can see and measure. And so that's our job. Everyone in here today is to tell that story, make it visible, credible, and impossible to cut. Budget requests framed only around response times or asking for money. Requests framed around this model make the case for investment. So we want to move towards value. And value, we have to have clinical outcomes. So that's your cardiac arrest, response times, your STEMI to time treatments. Are we responding quickly? And are we getting somebody on scene quick? And are we connecting them to a stroke center or to a STEMI time to treatment? Those are essential foundational items for a response agency. And I encourage you to know those numbers. Prevention and cost avoidance, though, is a huge aspect moving forward. And that's like fall prevention, chronic disease follow-up, MIH visits that avoid an ED trip that a payer would otherwise absorb. And we've seen a lot of movement towards hospitals, towards insurance agencies, like Blue Cross Blue Shield, or and even other private partnerships that are willing to support prevention and cost avoidance. And I'll say this for me, even for our fire department, with our MIH service, we were having we responded for about 6,500 lift assist calls a year, and we've been able to drop that number to around 5,000 now. And where our overall call volume has remained about the same, we've seen this number drop. And with that, we were getting a lot of firefighters injured just on lift assist, going to someone's house and lifting them up. We were getting back injuries and all these injuries. And we have been able to drop the firefighter injuries by over 70%. We've had firefighter injuries drop since 2022, 2023. We've dropped our firefighter injuries. We've reduced workers' comp costs. We've reduced time off a truck. So even when we're talking about prevention and cost avoidance on the external, we've made a huge difference within our own department and our members by preventing these injuries to mobile integrated health. Equity of access. So coverage in underserved and rural areas is a big deal. We'll talk about the Rural Health Transformation Program, or the bill that was passed. That is really going towards how are we providing the very best service to everybody within our state. And so equity is a big deal, and there's a lot of gaps, even with people getting to a PCP or having access to healthcare. Some of those can be overcome with mobile integrated health, and doing care in people's homes. It's something that I'm very passionate about. But to this point is, how are we addressing that? How are you addressing that in your community? What are those key issues that need to be dealt with, whether it's addiction or homelessness or certain areas of your town? What does access look like there? And then community resilience. This is something I talk about with MIH. It can really remove the burden when disaster strikes, something we don't think about a lot. But what does it look like when a weather event comes through? I know in our area, we can see ambulances. We've had fire trucks sit on scene for 2.5 hours before. And this was a number of years ago, and waiting on transport service to come. What does your resiliency look like when these disasters strike? So build the data story. You got to prove it. And so as I'm talking about telling a story is incredibly important, you absolutely have to have the data to back it. I always say my voice only goes so far. I have to back it with numbers. And so there's NERIS, or you got NIMSIS, CAD data. You get your operational department data with like response times, acuity calls. I can tell you in Tulsa from 3 to 6 p.m. is like our busiest time of the day. We know that the wave goes up on response volume and calls. What does it look like when you're taxed? Where are your gap areas in your city or your town that you need better support and better services? One thing we look at is, just where are we seeing the most overdoses or overdose related deaths? For example, in July here, it's July 22nd, we've had 14 overdose related deaths this month. in July. And so we're looking at those zip codes. We're providing targeted outreach now. We're going out there and providing education. But just knowing some of that data is really important. And then mobile integrated healthcare is the clearest value story fire-based EMS can tell. So treatment in place, alternate destination care shifts EMS from a transport service to a healthcare partner, and reduces avoidable transports, ED visits, and hospital readmissions. The outcomes payers and hospital partners already fund. And so there's money there. If you're not doing this or you're not addressing this area, I really encourage you to. It's a win for everybody, and the fire service is perfectly positioned to provide this service. We're community-based, and we know our communities well, and facilities can only do what they can do in the facility. And so I often say, hey, let us be an extension of the work you're doing in the facility or in the hospital in the community. And that's what we're really good at. But tracking those data, I can't express this enough. These are key points that I talk about all the time to city councilors, that we're able to keep people where they are. A lot of times we stabilize people in their home and don't take them anywhere and provide the service right where they're at. Identifying fire-based EMS needs. So before you can fund the future, you have to name it. A clear-eyed needs assessment is the foundation every critical budget needs. So what is your needs assessment? So as you're sitting here today, what are your needs? Are they workforce needs? Are you getting the right people in the door? Are you having the right credentials? Do you have a community paramedicine program? Do you need something else? Do you need another position to address the needs you do? What about fleet and equipment? If you're not planning for these budgetarily, you could be in trouble with ordering ambulances or fire trucks, cardiac monitors. What about the life cycles of those? When you're budgeting, do you have a plan? We just bought about $1.2 million in LifePak 35 monitors. But we did it over a number of years. We didn't do it all at once, and we wanted to stagger it out because we don't want all of our stuff expiring during the same year and have to have that fund come up at the same time. So for us, and generally speaking, these monitors last about 7 years. So what are your cycles for your equipment? Are you staggering those, or are you buying them all at once? And it may depend on if you're using operational budget or short-term capital funding. But what does that look like for your department, and how are you planning for those costs? Technology and data. We spend a decent amount of money on Tulsa Fire Department in technology, softwares to keep up with today's demands on our reporting, on our data analysis. We actually do. I got a drone in that picture. We do some drone stuff in Tulsa. So what does your support for that technology and data look like, and how are you integrating that within your overall budget? Training and education is always a big item and very important, and provider wellness. So making sure that you're preparing your workforce and preparing your members to be successful, very important item. Turning a needs list into a business case. So a list of needs competes for sympathy. A business case competes for dollars. I think the fire service has opportunity for growth in this area. My grandpa was on the fire department for a very long time, and so I've seen this for a number of years. We are very good at taking care of the job, but in getting a job done, responding to the job done. What we're not so great about is documenting it or writing it and telling and capturing that information in the work that we did. But we've got to be able to talk about the fire service, and we've got to be able to talk about our programs as a business and thinking of it as a business. When we provide a service, it's no longer let's just take care of it and move on. We've got to document it. You've got to talk about task or time on hand, how long it took. What did you invest there? Did you damage gear? What does that look like? And being able to tell that story from a business lens, I believe will help gain more dollars. And it's been beneficial for me and my department in doing that. So you got to name the need, improve operational response, address community risk. What are you trying to accomplish in your department? Attach the data. This is the stuff we talked about. You've got to have the quantifiable data to back it up. Translate that to cost avoidance. If we do this, we can reduce this. I found in my space, to be able to say, if you fund this, I can improve homelessness, or I can reduce addiction, or I can improve these processes, or reduce firefighter injuries. So when you're able to pair that need with the data and then tell that story, and then tie it to the community value. I always say this, I listen to the mayor, I listen to the city council and leadership and say, what are they trying to solve? What are we trying to solve? And how can we pair those two things together? And when you do, you're going to get a lot more support. And the same goes with hospitals and other community partners. Last section, funding the future, current and emerging streams. So there's been a big rural health investment, and I think a lot of people have heard about it, big, beautiful bill. And so the Rural Health Transformation Program, a lot of money, 50 billion authorized to distribute over the 50 states. And it's supposed to be equally distributed to every approved state as a baseline funding and allocated by rural population, facility need, and application strength. Ultimately, I think important to say here is states have the discretion over the local deployment of how they're going to deploy that. And as you can see there, meaning the advocacy case must be made at the state office of rural health, not just in Washington. So you've got to state this case in your own state. And named priorities include expanding access to emergency services, enhanced coordination, telehealth, and rural workforce strengthening. And I love the telehealth piece, and I think there's great opportunity there. And somebody get on here and correct me if I'm wrong, but from my understanding is Montana received 233 million, which is the fourth highest award in the nation. So a lot of money that I believe is going there. Oklahoma received approximately 223 million. I'm directly involved with this state funding that's going on in Oklahoma, so I'll speak directly to that. We have created pay structures, indicated cap amounts on like MIH visits or telehealth visits or what that looks like. There is administrative oversight. There is money for vehicles and to staff vehicles for rural health specifically, and getting some of these teams set up. But really the goal is to kind of invest in improving that service and to rural health. North Carolina, as you can see, they receive grants for funding MIH and behavioral health and community paramedic expansion. So if you haven't done this, I recommend you reach out to your contacts. I don't know who your contacts are, but the Office of Rural Health and the state's approved Rural Health Transformation Plan will be the contacts. And I don't know Montana timelines, but I would get in contact with, because our money's going right now. We're already starting to move forward, and it's being distributed to agencies to enhance their response and their service. And happy to talk about that more offline here. But the broader funding landscape. So state EMS trust funds. So the very last slide, or the next slide that I'll have, is going to talk about diversifying it. And what I really like to hit home here is don't put all your ducks in the same pond, right? You want to diversify as much as possible. I was just in Maryland this last week at the National Fire Academy doing AFG and SAFER grants, and I saw some agencies that had multiple funding structures. And I think that's really good. And I think it's really important. If you put everything here, if something fails, or if you're tied to sales tax like we are and sales tax drops, what happens to your organization and your operation? So as you're looking at your department, is how are we diversifying what we're doing? Whether that's through donations, grants, Medicare reimbursement for transport services, or partnerships. We receive money. We work with a behavioral health partner. They invest money and dollars into positions to come in our apartment. So diversify your spending, and utilize as much of those community partners as you possibly can, and other resources. This is not a number to go off of, but this is just a visual illustration of what I was talking about. And diversify your spending, operating fund or your general fund, state and EMS grants, hospital and philanthropic, third party and federal grants. If you can diversify it, and I don't know the perfect breakup. If I do figure that out, I'll let you know. But diversifying it only strengthens the work that you're doing and insulates your system. So in closing, your budget isn't a spreadsheet, it's a strategy document. And I really think you should look at it as a strategy and not a rigid strategy either. I think more and more to meet today's needs, we can't be rigid in our planning. There's something called like adaptive planning. And I think that's really on point with today's needs is you need to have a method to your budgetary process, but don't make it so rigid that you're not able to be flexible and adaptable. And so build a data story before the next budget cycle opens, not during it. Engage your Office of Rural Health. If you're not done this, I really recommend you do this. Even if you've not started an MIH program, now's a great time to start. And if you do have one, now's a great time to strengthen it. Invest in MIH and treatment in place. They will help your operations, your overall operations. When you think of a fire truck and ambulance, those are very limited resources, very valuable resources. MIH can take the burden off of those and let them be available to respond to those structure fires and those longer transport service calls. And diversify revenue deliberately. Don't let it happen by accident. Start planning or finding ways as how can I diversify what we're doing on our department. With that, I appreciate everyone's time today. And if you have any questions, I'll take them.
Thanks, Chief Lemery. That was great. Does anyone have any questions now? Okay, we'll go ahead and let Chief Joles go, and then we will have a little time for questions at the end. So,
all right, is my screen showing okay?
It is. Your video is not, but that's okay.
Yeah, I moved a screen around, and it's not letting me get my video
that's
back.
Okay. No worries.
Nobody's here to see this beautiful bald head, so we'll just move right along. That was great, Justin. Touch on a few things throughout mine that may touch on some of Justin's EMS content there, but we'll go ahead and get started. So every state has EMS regulations through their through their Board of EMS. I say Kansas Board of EMS obviously too many times in a week. We all have compliance that we need to follow, and then we all need to follow documentation policies so that we have quality work. And with that being said, there's a lot of kickback on a lot of this, mostly on the documentation side. So we'll touch on that a little bit. Justin talked quite a bit about federal oversight and then state oversight, specifically with money. It doesn't change regardless of where you go or the topics that we talk about, but EMS providers all over the country, regardless of the entity, whether it's fire-based, EMS, transport or non-transport fire-based EMS, or third-party EMS, operate typically within a structured hierarchy of authority. And every decision that we make, from patient care to documentation, is usually influenced by the guidance from multiple levels, being federal, state, and local. The federal, is obviously the highest level of guidance from the government, and while the federal agencies typically don't tell us exactly how to treat the patients, they establish many of the standards that influence EMS operations. Some of the examples that we typically hear are CMS, or Centers for Medicare and Medicaid Services, the NHTSA, or National Highway Traffic Safety Administration. Some of those are big influencers in the way that we're getting paid or getting reimbursed, or maybe even grant opportunities. Justin just talked about being at the National Fire Academy for FEMA last week. NHTSA just closed their grant opportunity, last month. And I think that if you wrote the word blood in your grant, you're probably going to get some money. That was kind of their trigger word over the last couple of years is blood and blood products. Then if we hit the state side of things, each state establishes the legal framework for their EMS practice. Sometimes we're in favor of that, sometimes we're not. This includes not only certification requirements, but EMS licensure, scope of practice, state administrative regulations, and then everybody's favorite, investigations and disciplinary authority. The local side of things is typically within your city or your county. We have an Office of the Medical Director here in Johnson County, Kansas. It encompasses 8 fire departments and 1 county ambulance. We're all under the same state or all under the protocol, which is individual to our county. We adapt state regulations to meet some of our needs in our community, such as county EMS protocols, regional trauma or STEMI systems, destination policies, and then some mutual aid agreements. And then that finite medical directorship, some of his responsibilities in our case is developing treatment protocols, standing orders, medication guidelines, and oversight of all of our provider competencies. And then we also have agency policies. So although we are under the Office of the Medical Director's policies, the Olathe Fire Department may have different things that we do. So we all have standard operating procedures or SOGs or SOPs, or you might call them policies, depending on your locale. Documentation requirements are usually in that as well. We document different than the rest of the county. I think that we try to do it a little bit better. I think everybody probably thinks that. The other 7 or 8 departments in our county think that they do everything the best, which we all typically think. But we do have certain things that are different on our fire trucks than some of the other departments. And I just pick out mechanical CPR devices. We have something that's different than the ambulance service, and so that means that we have different policies on how we implement those procedures. So back onto the federal regulations, they're the ones that provide the foundation on how EMS systems operate across the country. We already talked about this. Sorry, I got a little ahead of myself.
Hey, Chief Joles,
Yes.
You're still just on your very first slide. It's not advancing.
Oh, shoot. Okay, well, good. Then nobody would have known the difference. Here you go. I was clicking the wrong button. Let me get back here. So on the agency policies, like I said, we have SOPs or SOGs, depends on what you call them. These do differ amongst whether it's state to state, department to department. We all know that. That's what makes the culture of our departments and how we shape our departments. Sometimes people are fans of some of our policies, and sometimes they're not, and that's usually when labor gets involved. So talking about documentation and why it matters, it's a legal record. It typically is scrutinized the most, not only by maybe some of your QA or QI folks, but typically by legal counsel if you have that directly affiliated with your agency. We're fortunate enough to have an attorney that's specifically allocated to the fire department here in our city, as well as the police department, and she works pretty close with us. We have a lot of oversight, but it's good oversight because she helps us navigate through some of these tricky legal litigious conversations that we have. But when we talk about documentation, typically our people roll their eyes and they don't want to have a conversation. They want to make their reports as short and sweet as they possibly can, and try to have the patient care record do as much of the work as they possibly can. I was on the line just like anybody that was on this call. We were all on the line at one time, and we understand what they're going through. There's a lot of opportunities to make those a little bit quicker now, and we try to do our best, but we still need really quality legal records. The PCR is often only written to communicate between EMS and the rest of the healthcare system until it's not, until it's requested by a lawyer, the patient themselves, which is sometimes ends up being a little bit trickier than having a lawyer because they want to know every single detail while the lawyer is just looking for the reason that they've been tasked to request those documents by the patient, or in the other cases maybe the family. But other reasons that we need really good documentation is for billing and reimbursement, and Justin talked about that. If we're not getting documentation to CMS, Medicare, Medicaid, or third party private insurance, they're going to deny the claim, or they're not going to pay what you think you should be paid. So if it's not considered an ALS type of call by CMS, they're not going to pay for ALS. They're going to say, this is what you wrote. And if you did something more, you should have written it the first time. We're not going to let you amend it. So billing and reimbursement really requires quality documentation, as well as your quality improvement folks. This is where medical directors and teams of that nature really dive into your documentation to evaluate the clinical performance or identify educational needs to further better your department or agency. And then research. This is the one that really makes our folks roll their eyes. They don't care about it most of the time. We all have people that do care, but for the most part, they don't really care about the research that some people might be doing in the back end. And so the way you do that is you include them in some of that research, and you have to include them to where they understand why they're doing what they're doing or what you're asking them to do. And then, of course, risk reduction. As we review some of these calls, it's for our own documentation. Is legal protection, and your report should demonstrate the assessment, your clinical reasoning, and the care you provided. And it should clearly explain why you chose one treatment over the other, so that you don't have to explain it again in the future. So we've said this hundreds of times to our own people. If it isn't documented legally, it may have never happened. And we know that we can recall a lot of things when we're put under the microscope, but sometimes we can't, and that's when our folks are typically kind of jammed up when it's time to sit in front of the court of law. So as chief officers, we have to shift the conversation about documentation, difficult conversation, of course, and all too often we unintentionally taught our crews that the only reason to write a good report was because they might end up in court one day. And while that doesn't typically happen, and we know that, I've only been called to court a couple of times, but it's typically not been under a call that I was on. It was more of an expert witness opportunities. And so while it can happen, it's usually not the primary reason that we should be expecting excellence in documentation. But the real reason is much bigger than just the liability, and every PCR is data. And like I talked about data, our folks don't typically want to know much about the data unless it's maybe set to them in a competitive way, maybe whose shift has the best cardiac arrest survivability rate, or somebody whose time on task or been able to deliver a patient to the hospital the quickest. Sometimes that type of data actually starts to matter, and it influences the staffing decisions, equipment purchases, training priorities, grant opportunities, reimbursement, things of that nature. So as chief officers, we shouldn't ask for excellent documentation because we're worried about court. We should be expecting excellent documentation because it's how we understand our system, improve our service, advocate for our resources, and then ultimately provide better care to our communities. So what makes an excellent patient care report? I think this is probably a fairly debatable conversation, but there are some needs that definitely need to be met. Obviously, recording what happened, it tells the complete clinical story so that anyone that reads your report, whether it's another paramedic or emergency physician, somebody from the billing office, QA, QI coordinator, or even an attorney, which could possibly be years later, should be able to understand exactly what you saw and what you thought, what you did. And our legal staff, she often reminds us that the reason that we're telling a good story is it's a snapshot in time that you're most likely not going to remember 5 years down the road. And so telling that story, no matter how minute it is important. And I often share with our folks, I'll send an email occasionally and I'll try to redact some of the information, but if it seems like a lawyer or a patient is asking to see their patient care record for whatever the reason it might be, we typically don't know why. We can assume if it's a car accident or somebody fell at Walmart, we can assume that there's something litigious happening. But I like to take those really benign ones that people are asking for, and I like to share that with the department to say, why do you think this person is requesting their patient care record? And it's typically something that's not important. And it seems not important to us, but for whatever the reason is, it's important for them to ask. And I just like for people to know that we're being asked all the time for people to see their own patient care records, and it doesn't always have to be on the legal side of things. It could just be for other matters that we have no idea. So writing good reports is important. We want to document every intervention that we performed, just as importantly, the patient's response to whatever we've done to them. We like I said earlier, we share an ambulance service with the entire county. And when we share that ambulance service with the entire county, our folks typically don't want to write everything that the county ambulance service did on the call because they don't feel that it's their responsibility to document something that their own people didn't do. And so we have some formality to the way that we write reports here in our county, and it's really cleared up a lot of confusion. And when the office of the medical director reaches out, he's able to, well, not typically the medical director, but the QA guy typically will be able to piece those puzzles together and say, okay, this is what Olathe Fire did, this is what Johnson County Medac, the ambulance, did, and be able to piece that together. And if there's some blanks, then he usually reaches out to fill in the blanks. So a great PCR doesn't just document the patient care; it tells the patient story so clearly. It tells it so clearly that someone who wasn't there can understand exactly what happened and why. So some of the documentation errors, as chiefs, we also have a responsibility to prepare organizations for emergency technologies like artificial intelligence, and that's, although that's been the trend to implement AI, and it does have a tremendous potential to improve EMS documentation. It can also provide organized thoughts, improve grammar, identify missing elements, but we also need to approach AI with caution. We have some AI built into our patient care record, and it builds the narrative. But what I see is it builds it in a fashion that the person didn't write it, because that person, they don't speak that way. They don't typically use those words. You hear people, you get to know your folks, especially if you're in a mid-size or a smaller department, and that they didn't write that. And so when they didn't write it, you can question them and say, did you write this? And they'll say, oh, no, I had AI do it. Can you please go back and reread what AI wrote? Because this is not an accurate picture of what you did on this call, because I was there, or I know that this didn't happen. And they need to start thinking of AI as an assistant, as opposed to not treating it like it's the author of the patient care record, and use it to improve clarity and organization and readability, but never to invent assessments or treatments that didn't happen, because that's where it's going to end up tripping up our people. And so our role as chief officers is to be proactive rather than reactive. AI is coming to EMS. Like I said, our PCR vendor does it. I think a couple of the other ones are using it as well. They're already integrating it into their platforms. And instead of resisting it, we should establish clear expectations and policies now, so that our providers know how to use the tools ethically and responsibly. So medication errors in EMS. This has been a fairly a regular topic around here. We just implemented HandTevi, which is a medication-based dosing app that also has protocols. And we know that we have medication errors in our system. They're very difficult to track because people are scared that there's going to be some punitive reactions by the Office of the Medical Director or the department itself on having medication errors. And so people hide those, and we don't want that. We know that it's part of EMS. We know it's part of medicine. There's no way that we can eliminate every medication error. It's just not possible. Healthcare has proven that it's impossible to prevent every single error, and it's our responsibility to build a system that makes errors less likely, to detect them sooner, and we respond fairly to them, so that we gain our people's trust, and then so we can learn from them and learn what we can do to implement safer practices. One of the interesting findings from reviewing some of the cases, just to prepare for this talk, is I assumed that there had been more fire chiefs terminated, 5 Bugle fire chiefs terminated for conduct that was done by paramedics or firefighters at several levels below them. And I really wasn't able to find very many. And maybe I just assumed that there had been many of them because there were a few here in the Kansas City area several years ago. But and I took out the details, but there were some in states that were all across the country, from West Coast to East Coast, and then here in the Midwest. But as you can see, like in number 1 there, a senior EMS officer diverted significant amount of controlled substances over about a year while overseeing the department's program. that's going to be a trend. It's not a huge trend, but if you don't have systems in place that somebody more than just one person is auditing what you are doing or what they're doing with controlled substances, you're setting yourselves up for failure. Um, we'll talk about it a little bit more in another slide, but essentially the DEA has new rules. And I encourage, regardless of what level you are, how far away you are from EMS, regardless of what division you're in, you should familiarize yourself that there are DEA rules and that you need to be doing some stuff to create some guardrails so that things like this don't happen and we don't end up having a third or a fourth or a fifth, I should say, case review on here. I will say that in this particular case here, there was a fire chief that was terminated, and it was a Missouri case. It terminated. The fire chief lost his job because somebody was diluting drugs, and how they came to that conclusion, I don't know, but it was maybe back in 2003. So it's been several years, and there's a lot of guardrails and things that have been put up in place to prevent that. But the common thread across all these cases is the medication diversion is rare, and but we have a lot of things that we need to do to prevent those things, and the oversight and having more than one person in control of it is really something we need to be paying attention to. So, like I said, the DEA's got some new rules that came out, I believe, in March of this year. Every department that has narcotics, they need to register. They need to register those with the DEA, and they need to have a DEA license. Need to have designated locations. This is new here. The list eligible station houses with the DEA license. That's the important one because we used to have a separate license for every single firehouse, and now everything can fall under just one. So that does make things a little bit easier. You want to make sure you secure every dose. I just talked to a gal today in Western Kansas, and I just asked her. I said, "Do you use what do you use for your narcotics tracking?" And she said, "We still use paper and pen, and we've got a cabinet that was built into our ambulance when we bought it in 2010." So not super old ambulance, but an older ambulance, and they don't have, and everybody uses the same code. So all the paramedics for that organization has the same code. So if I was a paramedic with her organization, she's got the same 1, 2, 3, 4 code as I have. And so there really would be no way of tracking whether I was the one who diverted those drugs or if she did it. Controlling the access. So having upgraded devices and technology to be able to control that access. Document the chain. We do it digitally with a program on our phones every single day, and then audit, and then make sure that you're reporting to the DEA. And auditing, I use our audit program for a way to get out to the stations and see our folks. It gives me an excuse to go around to the stations at least once a month and visit with our people at least on one shift. So that's has nothing to do with EMS, but it's an opportunity as a leader to go out and talk to your folks, and we know that we barely have time to do that if you're an office person. Back to the courtroom testimony. We do a blood draw program for the police department here, and my people hate it. They've hated it since I implemented it in 2010, I think, or I don't even remember when I did, 2012, when I implemented it. They've hated it every single year. We just had a strategic plan, internal stakeholders strategic plan meeting yesterday, and it was written on the EMS page of getting rid of the blood draws. And the reason they don't like doing it, I don't blame them, is they have to get up at 1 o'clock in the morning, 2 o'clock, 3 o'clock in the morning and go draw somebody's blood who is probably not going to be that cooperative. And so having those blood draws has been beneficial for the police department and getting drunk drivers off the road or intoxicated individuals out of the public. But it does come at a cost for our folks. But we are probably subpoenaed for our blood draws more than any other EMS call. So there is some consideration to not have our people going through that, just to be able to help the police department. And that's not throwing any shade at the police department, because we want to be good partners, but they certainly, the longer we go on the blood draws, waiting for them to do that, they're metabolizing their evidence. And so, they want to get it done as quickly as possible. But if you do encounter, your folks asking for some help to prepare for for a courtroom testimony or a deposition, just remind them that they can look at their report. They shouldn't change anything. They can add addendums. You can change your report at any time. You just need to make sure that you're doing it in a recordable way so that they can see what you did change. Your memory can be jogged at any time. Just make sure that the lawyer is privileged to that information of something being changed and giving a why so that you don't do it inadvertently. The facts are the witnesses and not the defendants. So what the witnesses are writing down are typically your crew, and you want to make sure that you ask your crew if they remember anything as well. And then our responsibility as chief officers is not to turn the personnel, our personnel, into attorneys. We want them to just answer the questions as easily as they can. Our responsibility is to prepare them to be credible professionals. And the credibility begins long before anyone walks into the courtroom. It starts with the quality of documentation. They can't typically request documentation from other calls because that's a HIPAA violation, but they can subpoena other records that might show the demeanor or the quality of employee that you might be putting on the stand. So we have to be prepared for that. And I want to point out something that often surprises people. In the nearly 3 decades that I've been in EMS, I've found that the vast majority of depositions and courtroom testimony revolve around the documentation. But it doesn't happen all that often. But when it does, you want to make sure that you've got a good report to base your credibility off of. When an EMS provider does receive a subpoena or deposition notice, we just want to ensure that they're supported, prepared, and connected with the appropriate legal counsel. And if you're in a community that doesn't have that readily available, you should probably think about what is that going to take to be able to get somebody. We don't typically get deposed or subpoenaed within, there's typically a good chunk of time ahead of time. It just depends on what's on the courtroom docket as far as timeline goes. And we just want to be mindful that we're giving people ample time to prepare. And we're not scripting their testimony because we don't know exactly what's going to be asked, but we do want to make sure that we're putting them in front of people that can help them prepare for successful deposition or testimony. As chief officers, our responsibility is to build the systems that support compliance, accurate documentation, accountability, and continuous improvement. And strong leaders protect patients, support providers, and reduce organizational risk. And ultimately, we do more than manage the problems. We create the culture that prevents them. And that concludes my session.
Thank you, Chief. I appreciate that. We're just right at 6:30, but if you're willing, if anyone has questions, we can take a couple of questions. Does anyone have any questions for any of these gentlemen? Okay. Well, thank you so much. We really appreciate you. This was very interesting and great addition to our program. So thank you so much. And thank you everyone for joining us tonight. And we hope you have a great, thanks, Lindsay. Have a great rest of the month, and we'll see you next month.
Thank you for the opportunity. We appreciate it.
Thank you. We'll see you in Kansas City soon.
Yes. Don't bring your jackets.
All right. Take care. Good night.
You too.
Bye-bye.